Intensivists from the Hospital Santa Maria of Lisbon. Francisco, please, thanks a lot.
Okay, welcome very much, and thank you very much for the invitation. Welcome, everyone. I'm here to talk about the practical challenges of out-of-hours ECPR. I have no conflict of interest, so we're talking about an ECPR that happens when not everybody is on the unit or on the operating room. First, let me start by giving the definition of ECPR. This is how I divided my presentation, the practical challenges. I will show you a paradigmatic case and then the conclusions of my presentation. So according to also ECLS, the ECPR is when ECLS is used as part of the initial resuscitation from cardiac arrest with ongoing chest compressions during ECMO cannulation. I know this is basics, but it's very important that we all speak in the same language so that we understand what you're talking about. So hemodynamically unstable patients placed on ECMO without CPR are not considered ECPR. And if ECMO is started after return of spontaneous circulation, it is not also considered ECPR. So we have to cannulate the patient while doing chest compressions. If we go to the ELSO registry and take a look at how many cases of ECPR have happened in neonatal and pediatric patients, we find the number is quite large. Of course, this is all the registry, but it's 2,000 ECPR ECMO runs in neonates. They have a survival of ECLS of 70%, but then only 42% survive to discharge or transfer. Of course, this is actually quite good. 42% of patients that were resuscitated with ECMO survived and were discharged. When we look at children, the numbers are even bigger. 5,000 children resuscitated with ECPR, and of these, also 42% survived to hospital discharge. Of course, this doesn't mean that these 42% were neurologically intact, but it's still quite an encouraging number. So what are the practical challenges? I'm going to the subject of my presentation. I divided this in 4 challenges: the human resources and skills, the equipment, the setting, and how to choose the candidates. And this last point will be discussed further with my next colleagues. So the human resources and skills, so to put a child on ECMO, you will need at least these people that are shown here. That's the surgeon to do the cannulation, especially if it's a small child or neonate. You will need the ECMO specialist, the nurse and the doctor. You will need the bedside nurse, and in most cases you will need a perfusionist. So this will be the main resources in most units. Of course, you know that a lot more people are involved, but this would be the basics. And this can be a challenge because we are talking about out-of-hours ECPR, and these people are not around 24/7 in many centers. So this could be an issue. And they have to be highly trained in starting the ECMO and doing it quickly and efficiently. Then we need to have the equipment. You need the ECMO machine. That should not be a problem. Of course, now with the COVID-19 pandemic, that was a problem, but usually you have a machine available. You need to have the circuit and the oxygenators. That's all part of the normal equipment we have on an ECMO unit. But then there is the question of if you want to keep an oxygenator already primed with saline to make it quicker to do to start the program or not. It's quite debatable. Some units keep it, some don't. Of course, while the surgeon or the doctors are cannulating, the perfusionist will prime the circuit with saline usually very fast, so it's not required. But if you are in a very busy unit where these cases happen quite a lot, sometimes it's a good idea to have an oxygenator already primed. You need to have all the cannulas quickly available for peripheral and central cannulation. And it is very useful, especially in cardiac surgery centers, that the patient has a list of occluded vessels so that you won't lose time trying to cannulate a vessel that is already occluded from previous procedures. So this can be very useful, a quick chart where you can just take a look and know where to cannulate, so not to lose time. In the case of neonates, you cannot prime the circuit only with saline, so you need to prime it with blood products, and this could be an issue because sometimes blood products take quite a while to be available, and every minute counts. So if you have a very unstable child, it could be also useful to have red blood cell back in the refrigerator on the unit, for example. Because if you can keep it at the right temperature, it will last the same time of amount that in the lab. But this depends really on the conditions of where you are working at. And it's very, very useful to have a checklist with the contacts, who should you call, and the numbers where you can call them, all the equipment you need, so that it will be faster, and the protocols. So each unit where ECPR is done should have a protocol to follow each step of the way, and this will make it very much smooth, the procedure. Another practical aspect is the setting. Where are you working at? Is it a cardiac ICU, where cases of cardiac arrest are occur more often, or do you work in a non-cardiac PICU where cardiac arrest is a much more rare event, and probably you are not as used as in CPR as in a cardiac ICU. So this is really very important, because the way you prepare your program will be quite different. Do you have a surgeon who is available 24/7? So if you work in a busy cardiac ICU, probably you will have a surgeon available 24/7. But if you work in a non-cardiac ICU, probably you will not have a surgeon with expertise in pediatric or even neonatal cannulation available 24/7. Even in some large centers, you don't have the people with these skills available all the time. And some places work on an they work on an on-call setting. Some places call the surgeons from home, and they have like 10 to 15 minutes to arrive. But of course, if you're talking about ECPR, what you want is the surgeon to be on the right there, the most in very quickly. Another very important question is the frequency of cardiac arrest. How often do you have cardiac arrest in your unit? Do you have it once a week, once a month, once a year? And this will probably define what kind of program you should have. So is it a low or a high volume PICU? So all these questions are very important, because they will determine if you should have an ECPR program at the beginning and how you are going to prepare your program. The next practical challenge, and I think this is probably one of the most important ones, is how to choose the candidates for ECPR. I put here a list of good and bad candidates. This will be discussed further in the next session, but just a personal point of view, if you have an in-hospital cardiac arrest with a patient with a cardiac diagnosis, that will probably be your best candidate. And if you have an out-of-hospital arrest with a non-cardiac diagnosis, that will probably be your worst case scenario. Another good candidate is acute fulminant myocarditis. These are very good patients to put on ECPR, one of the best outcomes. An obstructive dialoctosis shunt is also a good candidate, or a post-operative period in cardiac surgery. So all these are good candidates, and you should consider ECPR. The bad candidates would be the single ventricle congenital heart disease. If there is very severe pre-ECMO acidosis, it has been shown that the outcome is worse in these patients. a rupture during cardiac catheterization, of course, you are in the cath lab, you have the expertise, but actually the outcome is not very good in these patients. If you have severe pulmonary hypertension or a massive pulmonary embolism, these patients do very poorly because traditional CPR will not be effective. You are doing cardiac compressions, but if there is an important obstruction in the pulmonary flow, the CPR will not be effective. And if you have children with genetic syndromes, with many malformations, of course, are also bad candidates. So I think this list could help a little bit to choose which candidates should be put on eCPR. I will now going to show you a patient that we had a few years ago in our unit. It's a 6-year-old girl, previously healthy, that came in with the diagnosis of fulminant myocarditis. She was retrieved to our PICU on maximal inotropic support and mechanical ventilation, and she arrested 1 hour after admission. So we started doing CPR. Because we were already thinking that she might need ECMO, the surgeon was already called, and we were starting to look at the equipment that was going to be needed, so this made things a little bit faster. And she was successful put on ECMO on the first day, actually on the first hour. It took us quite a while, more than 60 minutes of CPR, but because if it's a myocarditis, the heart was dilated, there is no obstruction in the pulmonary flow, so actually it's very easy to resuscitate this child. She would actually wake up when we're doing cardiac compressions, and then when we stopped, she would, of course, go into arrest again. But we were able to put her on in VA ECMO. She was decannulated at D8 and extubated on day 12. And on day 14, she was transferred to the ward. At the first 24 hours on ECMO, actually the heart was almost stopped, so the arterial line on the femoral artery didn't have any pulse. She was fully supported by the ECMO. But then after 24 hours, the heart started beating again and actually made a very good recovery. On day 21, she was discharged home, and at present, she is fully recovered. So this is her right now. Of course, this picture has the authorization of her and her family to show. And this was a successful case of eCPR. So to conclude, eCPR in cardiac patients and in hospital cardiac arrest offers the best outcomes. Usually, I used to tell my students and my residents that when the heart of a healthy child stops, something went very wrong. And when the heart of a healthy child stops and we are not able to restart it with conventional CPR, then something went very, very wrong. So we should give it a serious thought if we should put a patient like this on eCPR. It's completely different if the cause of the cardiac arrest was primary cardiac. So we have to really choose our patients so that we have the best outcomes, and with neurologically intact children, that's what we want. Good quality CPR is essential, and skilled teams, protocols, and education are key components of a successful eCPR program. So to put a child on ECMO requires a very skilled team, but to put a child on ECMO during CPR in a very short amount of time requires even more skilled team, very good protocols and education and simulation training. So that's my messages, and thank you very much for your attention.
Thanks a lot, Francisco.
Thank you. Right. Well, we're doing excellently for time. That's the good news. So no one should be too pressed. We have a debate coming, but we're going to introduce the debate participants individually, and then we'll have